5 times more potent than heroin. And butyrofentanyl is another fairly common fentanyl analog. There's a bunch of them out there, which we won't go into too much detail. One that we hear about is carfentanyl, and this is a veterinary anesthetic used on large animals like elephants and things like that. And it is about 50 times more potent than fentanyl. So it gets into, so if you think of that purple box from the last slide, you know, this purple box is 50 times smaller than the heroin purple box. And then you go 50 times smaller than that, and there's your carfentanyl box. So super, super potent drug. We don't see that very much because once it emerges in a community, it pretty much disappears. You know, a bunch of people die, you know, 18 people die, and then it disappears completely because everyone who uses it dies, basically. It's just too potent to titrate for humans. Great for elephants. Next poll. All right, fentanyl is a scheduled drug. Which schedule is it in? And we're referring here to the Drug Enforcement Administration scheduling of drugs in the United States. Schedule 1, which means no medical use. Schedule 2, medical use but high risk. Or Schedule 3, medical use but moderate risk. I'll give that a moment. How are we doing on count, Claire? Are we ready?
We're ready.
All right, so most of you got it right, medical use but high risk. That's great. And Schedule 3, medical use but moderate risk. So I'll give some examples of drugs in different schedules. In Schedule 1 is cannabis, which has no medical use per the Drug Enforcement Administration, and heroin is Schedule 1, and psychedelics are generally in Schedule 1. In Schedule 2 is things like cocaine, because there are still medical uses for cocaine used generally in the ENT procedures, head, neck, and procedures, and as well as most of our prescribed opioids, so morphine, codeine, oxycodone, all that is Schedule 2. Fentanyl is in there as well because it has some really profound and important medical uses. Schedule 3 is things like buprenorphine, the opioid we use for opioid use disorder, which is a much safer opioid, and thus is in a slightly lower schedule. So a little bit of history on fentanyl. Where did it come from? It was initially synthesized in 1960 and approved by the FDA in 1972. Approvals back then were improving, I think, then, but still a different beast than approvals today. So one of the forms that fentanyl took was a fentanyl patch, and that we saw the first kind of misuse of fentanyl patches in the 80s. We also saw, we've always seen through the history of fentanyl some misuse by fentanyl by anesthesiologists who work with it a lot because they're using it as a surgical treatment, as one of the key anesthetic agents in surgery, and sometimes they try those medications and you end up, it's a common drug resulting in problems for anesthesiologists. In 2006 was the first real sort of illicitly manufactured fentanyl outbreak that we had, and this really occurred in the eastern half of the country. A couple thousand drug overdose deaths, fentanyl overdose deaths, were attributed to this presence of fentanyl in the community. And there was one lab in Mexico that was busted, basically, and it stopped the outbreak completely. then it kind of disappeared off the scene again for a while until 2013. We started to see a rise in deaths, really started to see it in 2014 and 2015. By 2015, it had really set in, and we saw those huge spiking numbers on the eastern half of the country. It didn't really hit the western half of the country. It kind of seeped in little by little each year, but really hit in probably 2019, maybe 2018, 2019, and 2020 for sure. There was a little bit of a barrier to it hitting the West Coast, thought to be primarily because of the type of heroin on the West Coast, which is black tar heroin coming up through Mexico, as opposed to the type of heroin on the East Coast, which is powder and more easily mixed in with fentanyl. As you can see here, we've also seen little bits of things like the U4700 and carfentanil and things like that, other sort of synthetic analog outbreaks that have popped up in the meantime. So a little more on the sort of appearance of fentanyl in the East and the West. So the Eastern US, it's usually mixed with heroin, and it can be anywhere from a white powder to a brown powder. Initially, people who use drugs were trying to identify it based on the color. So if it was more brownish, they'd assume it was heroin. And if it was white, they'd assume it was fentanyl. So people who wanted to move fentanyl started just adding a little bit of food coloring or other products, or brown products to their fentanyl to make it look more like heroin. So the color doesn't actually end up helping us. In the Western US, as I said, the heroin's black tar. It's really rarely mixed with fentanyl. It pops up from time to time, but it's tough to mix in such a potent drug in a meaningful way in the tarry product of heroin on this coast. So usually fentanyl is actually sold basically as its own product, as an off-white powder or crystals, things that oftentimes look like stimulants. So people who are using cocaine or methamphetamine might actually mistake the product for, may mistake fentanyl for a stimulant, and with unfortunate results. There is, of course, sometimes, and in some communities more than others, we don't see it so much in San Francisco, just here and there, fentanyl stamped as pills. These are counterfeit pills. These are not, for example, it's not really accurate to say that it's a Xanax pill laced with fentanyl, because it's not. It's actually fentanyl stamped in the shape of a Xanax pill. So there are some communities where this is sort of the dominant form of fentanyl that we see causing problems. But in our spot in San Francisco, it is really mostly sort of a white powder or crystal substance. So how does fentanyl sort of feel differently from other drugs? The first thing to think about is that it is the actual sort of qualitative nature of the feeling or the high is quite different. If you think of opium, oftentimes it's been referred to as the celestial drug. So it's kind of a whole body experience. Heroin, Lenny Bruce referred to it as, it's like kissing God. The first phrase of that sentence was, "I'll die young, but..." And heroin can also be sort of celestial, particularly the black tar heroin. It can be more of a full body experience because there's multiple compounds in it. The white powder heroin is a little bit sharper than that. And then the fentanyl effect is much sharper and shorter of a high. So it's really more sort of pure new opioid effect, and you're not getting these sort of other ancillary sort of whole body experience effects. The next thing I want to go into is a little bit on how it's used. It is, the medicinal form of fentanyl we most often see is the patch. There are also things like lollipops. The patch is, if you're going to use it, generally you're dissolving the patch, trying to get out the fentanyl, and then you're putting it into solution and injecting it. And injecting fentanyl is most of what we see around the country. There is a lot of smoking or chasing of fentanyl in San Francisco. That it's pretty unique to San Francisco from what I've seen. I think it started to pop up in some other communities on the West Coast, but I haven't heard of it much on the eastern half of the country. We definitely have seen fewer injection-related consequences when people transition to smoking, and we've had a lot of people who inject who actually transition to smoking. However, I'm not sure it has the kind of impact on overdose prevention that we would expect. So with heroin, if you smoke instead of inject, you're far, far, far less likely to suffer an overdose. I'm not sure if that holds with fentanyl. And I think the part of the reason might be the potency of fentanyl. When you're smoking or chasing heroin, you have to take a number of puffs to get the effect that you're seeking. So you can finely titrate the effect. With fentanyl, from what I've heard, it's one or a couple of puffs and you're done. So you're not getting that finely titrated effect. That is speculation at this point, though I can't confirm that with any data. All right, we're on to our next poll. Can you overdose from touching fentanyl? Sorry, I should say you can overdose from touching fentanyl. True or false? All right, we got a split here. Hooray. I love it when there's a split. It makes for a much more interesting conversation. Actually, before I go into this, I'm going to answer a question from Jennifer Burrows on the chat. Why do you think there's a difference in the form between Eastern US and Western US? I think that is primarily there's a couple of possibilities. I've hung on to the different forms of heroin that are there. So the western half of the country has black tar heroin, the eastern half has white powder heroin. And so that they're coming from different places, and they're also dominated by different dealer networks. So so you don't see a lot of interaction between those two sides. You get a little bit of interaction in the middle of the country, but they're kind of controlled by the dealer networks. And excuse the interruption. So you don't see too much overlap between those. In addition, in Vancouver, the heroin's coming from Asia, and it's white powder. And in Seattle, it's black tar. In Vancouver, it's white powder, and you don't see any mixing between those two. So it's a pretty solid line. And the fentanyl in Vancouver is mixed in with the heroin, whereas the fentanyl in Seattle is largely separate. So from touching fentanyl. All right, so we're going to go into this one. I like the even split, and we're going to spend a slide talking about this a little bit. The simple answer is no. You really can't overdose from touching fentanyl. But I'm going to give you the more complex answer as well. With a massive exposure, like a half a kilogram, some forms of fentanyl all over your skin, some forms of fentanyl can slowly, over hours of continuous exposure, penetrate the dermis. This is, not really happening. The next question, though, is, but there's a transdermal fentanyl patch, so it must absorb through the skin, right? No, the transdermal fentanyl patch is specifically manufactured with additional components that allow it to penetrate the skin, and it takes hours and hours and hours to penetrate the skin. So these are patches you leave on for 24 hours, and you get a tiny little bit of fentanyl seeping into the skin each hour. So there's the fentanyl that's manufactured, that's on the street. It has not been formulated to penetrate the skin. And you really can't overdose touching fentanyl. This is, even carfentanil exposure and the studies that have been done with it, and given how intensely potent it is, you'd be really worried about that. But even that just can't result in the kind of rapid, significant toxicity that's been reported in the news media oftentimes. Most law enforcement actually believe that any contact with fentanyl can be deadly. And unfortunately, this means that they're afraid to touch people who might be using fentanyl. And this leads to really horrible stigma. So this concern is not evidence-based, and the evidence that's been collected, including a lot of laboratory studies, it doesn't support this as being possible. So what it ends up being is just horrifically stigmatizing, unfortunately. Okay, talking a little bit about interventions now. So the CDC has this wonderful system called SUDORs, where they're looking at drug overdose deaths. And this is one of their papers from the SUDOR system, where they looked at overdose deaths from opioids and stimulants in various combinations, and tried to look at where there were opportunities for intervention. And these are data from 2019. So on the far left, you can see that about 2/3 of people who died from opioids or stimulants had at least one potential opportunity for intervention, and those opportunities prior to their death. And those opportunities included recently having been released from an institution, having had a recent prior overdose, having a mental health diagnosis, ever being treated for a use disorder, having a bystander present at the scene, or having the actual drug use itself witnessed. So there are opportunities for interventions among the people who are dying. You know, it's one of the tricks about intervening in an overdose is you really can't do it if you're completely alone, if there's nobody there. So one of the goals of the efforts to improve bystander response and sort of utilize bystanders to respond to overdose is to try to get these deaths that involve a bystander being present or drug use being witnessed, getting those as close to zero as we possibly can. That in theory should be possible. And so that, you know, those last two columns, those are the ones that we can really make a dent on with bystander response interventions. But one of the key things to think about with fentanyl is the relative risk of an overdose. So these data, the top line showing the high risk of overdose, the relative risk of an overdose event with prescribed opioids, medicinal opioids, heroin, or fentanyl. So heroin's about 4 times more likely to result in an overdose, and fentanyl another 2 and change, about 2.5 more times more likely than heroin to result in an overdose. And these data come from the supervised injection facility in Sydney, Australia, where the participants come into the facility and report what drug they're planning to inject. And so it relies upon them having a sense as to what they're injecting. And when they report that they're injecting fentanyl, so knowingly doing so, they still have 2.5 times more risk of overdose event than those who are knowingly injecting heroin. So you can imagine if you add on the, I have no idea, I think it's heroin, but maybe it's actually fentanyl, then that probably is an even greater risk of an overdose event. And then the next category is the likelihood of death when overdose occurs from fentanyl compared to other drugs. Don't have solid data on this. This is the relative risk of this is data from people coming into emergency departments and with either a medicinal opioid, a heroin, or a fentanyl overdose. And those with a fentanyl overdose were twice as likely to require advanced respiratory support, like intubation. So that's not a perfect corollary to death, but it's the best we have at the moment. So all of this is to say, you know, the risk with fentanyl is so much higher than what we were dealing with a few years ago. Fourth poll. True or false? Naloxone does not work on fentanyl. And while we're waiting for that answer, I'll look at some of the questions in the chat. How do we get the message across to law enforcement about, and where does the misconception about fentanyl come from? These are tough ones. You know, it's really hard to convince somebody that something isn't true when it starts making the rounds and when media find it exciting to report on. So it's a struggle. I don't have an easy answer to that. And then where does the misconception come from? That is a, I kind of tie that back to stigma, frankly. Okay, True or false? Naloxone does not work on fentanyl. That is false. Very good. Well done. So naloxone does work on fentanyl. It's used all the time in the medicinal setting, and it should work really just as well as it does on other opioids. The data from the naloxone distribution programs suggests that the number of doses needed is actually not different with fentanyl compared to other opioids. The biggest difference in terms of how much naloxone people are using is the expansion of naloxone to lay people who do not use drugs. So when somebody is using drugs with their friend and their friend turns blue, they administer naloxone, and they try to administer as little naloxone as they can to get their friend safely through the overdose, because they know how unpleasant that withdrawal is. When another person who is not familiar with the drug use practices or the addiction experience, et cetera, administers naloxone because they witness an overdose, they tend to administer a lot and frequently. So you're supposed to wait 2-3 minutes or more between naloxone doses to wait for a response. But when you don't experience this all the time, 30 seconds feels like 5 minutes. So people tend to administer one dose, 30 seconds later, they administer another, and they just use up all the naloxone that they have. And then the person, if they do wake up, they have really severe withdrawal symptoms. But the reality is and the big problem that we're dealing with is the window for bystander response. So after the use of an opioid, if you use heroin, respiratory depression happens over the next half an hour or so. It takes a little while to reach the point where you're not going to respond to stimulation. And then it takes, it's thought to be about 30 to 90 minutes before you progress into cardiac arrest. And you can think of cardiac arrest as essentially death. That's the only way to survive that is advanced cardiac life support. And so, if you wait 90 minutes after someone uses too much heroin to administer naloxone, it's really not going to do much of anything. And in contrast with fentanyl, the time course, these are estimates. We don't have solid data on the time course, but it is way shorter. The progression between use to cardiac arrest is somewhere in the 15-minute range. What that means is that you really don't have much time to respond to a fentanyl overdose. And the likelihood that naloxone is going to make much of any difference, it's not about the type of opioid nearly and as much as it is about the window for response. Fentanyl crosses that blood-brain barrier really quickly. Respiratory arrest happens really quickly, and which means cardiac arrest happens much more quickly than it does with heroin. Heroin overdoses are generally a slow experience. It's extraordinarily rare to see a needle in the arm of somebody who overdosed on heroin, but it is quite common with fentanyl because it just happens so much faster. So in order to effectively respond to fentanyl, you got a much narrower window, and most overdose reversals are done by other people who use drugs. That is the workforce out there saving lives. But they may be too high. They may have used drugs at the same time and be too high to be awake in that 15-minute period. So they're going to be awake within the 30 minutes that they need to respond to a heroin overdose, but maybe not in the 5, 10, 15 minutes they need to respond to a fentanyl overdose. So fentanyl has really reduced the power of our bystander response interventions, unfortunately. This is some data from a model looking at drug overdose and naloxone distribution. And in general, absent any interventions, we expect about 1% of people to die from overdose if they are using heroin each year. And without any interventions, we can expect about 4% of people to die from fentanyl overdose each year, if they're using fentanyl. And with naloxone, that percentage gets down to about 0.7% if you have a really robust naloxone program with 80% coverage of the community. And it's going to bring you down to about 3.4% in the fentanyl community. So the problem here, so it looks like naloxone's not working, right? Because if let's say you have a great naloxone program and you were having 100 deaths a year, and now you're having 450 deaths a year. And so you think, oh no, this isn't working. But the reality is it is working. If you didn't have that naloxone program, you'd have 550 or 600 deaths a year. So the fundamental issue is that we're just working from a new baseline with a much higher risk drug in the market. So what are our general strategies to try to respond to this? So here's a list of some public health interventions. I'm not going to go through all of these in great detail, but give you a little bit of a sense of what's out there. The first is naloxone coverage. And then we'll talk about medications for opioid use disorder access, behavioral interventions, safe spaces, safe supply, drug checking, and structural and social determinants of health. So in terms of naloxone coverage, the main workhorse for this is harm reduction programs. They do, that is the vast majority of the millions of naloxone doses that are distributed each year is through these programs. They reach the people who are most in need of naloxone and who are most likely to actually administer naloxone. So the biggest bang for your buck and really the workhorse and the power of this intervention. They can expand that and do targeted outreach in criminal justice and low-income housing settings, places where overdoses are more frequent and people are at greater risk. The next thing is prescribing and dispensing by medical providers and pharmacies, and that's some of the work that we do in academic detailing. I think this is really important, and when it's not being done, it's a huge missed opportunity. But at the same time, I'm not under the illusion that this is the majority of reversals happening. It is a distant second in importance to harm reduction program distribution. Emergency medical interventions and in emergency medical services, there are many programs where paramedics are handing out naloxone now in calls that they have that are drug related. And then other settings, substance use disorder treatment, mental health settings, faith-based settings, nightlife settings. You can find that sometimes around the Bay Area. You can find containers of Narcan outside of the bathroom at local nightlife settings. And you're reaching not just people who use opioids, although that's the first goal. The additional goals are reaching people who use other drugs because of the concern about other accidental use of fentanyl for people who use other drugs, and reaching out to friends, family, and neighbors. In terms of medications for opioid use disorder, the efforts are to increase the availability of it, increase the use of low threshold services where you're not necessarily requiring somebody to commit to abstinence and recovery when they're going to use a medication for opioid use disorder. Basically, every day that they take buprenorphine or methadone, there is a day that they are very unlikely to die from an overdose. And then the next thing is thinking about novel initiation practices. So the first thing on novel initiation practices is methadone. One of the problems with fentanyl is people, when they use it, because it's so much more potent and it's so cheap, their tolerance gets extraordinarily high. And then when they go and use heroin, it feels like they're using water. So they're not getting any effect from that. Their tolerance is super duper high. So when they get started on methadone and we start slow with methadone and increase the dose, they can't handle it. We have to increase the dose faster because otherwise they're just in horrible withdrawal. Then the other thing is buprenorphine. So buprenorphine, frequently, the big concern about starting buprenorphine is it has this ceiling effect where you only get so much effect out of buprenorphine before it caps. And which means if you're on a full agonist, if you're using heroin or morphine or something like that, and you just take buprenorphine, you go into precipitated withdrawal, which is a horrible experience. With fentanyl, so the way we manage that is we have you stop your main opioid, you go into withdrawal, and then you take the buprenorphine and you feel better. With fentanyl, we have people stop and they go into withdrawal and they take buprenorphine, but they still have so much opioid on board that they still go into precipitated withdrawal. So it is very tricky to start buprenorphine with somebody who's using fentanyl. The solution that we've found and that is being used frequently around the country is this overlap initiation approach, sometimes called microdosing. And this at the bottom of this page is an example of a microdosing protocol where you start somebody on a 0.5 milligram of bup 4 times a day for day 1, and then you increase it each day until you get up to a therapeutic dose, and then you stop the other opioid. So an overlap initiation approach. I think this is going to become the norm for starting buprenorphine. There's still research that needs to be done, and there's a dozen variations on this approach out there. So it's a field very much in flux, responding to serious concerns around fentanyl. The next thing is thinking about just drop-in programs, and there's spaces for people to be, these traditional drop-in programs. I think that's been a huge issue for urban centers, is they've lost a lot of these kind of places that people can actually be. You've got sobering spaces like the Spot in Boston. You've got consumption spaces like Vancouver's Insight. These are all fantastic. We need as much as we can. There are some real barriers to things like consumption spaces. New York City has started one. It is fantastic, but most places aren't going to be able to start this. And so the first thing to know is that if somebody is around other people, they're very unlikely to die from an overdose. So just having spaces for people to be around other people is a reasonable first step in terms of trying to address overdose mortality. In terms of behavioral interventions, there's a lot of public messaging and education that we can do that's been missed a lot. There's contingency management. This is particularly good for stimulant use. This is paying people to not use drugs. And that Medicare Services recently approved a pilot of that, and we're doing that starting that in California, reimbursed through Medi-Cal, which is very exciting. Ton of data for this intervention, but it is vastly underused. And then, non-injection routes of administration, is this an overdose prevention approach? I used to think so for heroin, but I have a tough time knowing if that's true for fentanyl. Counseling interventions, overdose prevention interventions. This is one of our studies from some years ago. This was a pilot that showed a big reduction in overdose events with a counseling intervention. So there's a couple of counseling interventions out there that can be considered, and because I think part of the issue is we can't just respond to overdoses anymore because we don't have enough time between the use event and the death. So we have to put a lot more energy in preventing the overdose from occurring in the first place. Safe supply is another topic. This is a picture of a vending machine that provides long-acting morphine to people in Vancouver. And there's a lot of efforts in Canada to do safe supply to deal with this, to try to reduce the use of the extraordinarily dangerous fentanyl and synthetic opioids. So in the US, we are stuck with agonist treatment. That's kind of our closest thing to safe supply, is methadone and buprenorphine. And the next step, I think, would be really working on innovative agonist treatments using morphine, hydromorphone, or heroin injection programs that have proven effective around the world. And then, easier access to supply, to really lowering the barrier to the safer options. And then the other thing is thinking about our prescribing reforms. And this fits into a lot of Chow's work, which is, recognizing that there are real risks when we're cutting people off from prescribed opioids. Unfortunately, many patients probably shouldn't have been started on opioids in the first place. And when they were, many of them developed, some of them at least developed, significant problems with their use, and providers are put in a really difficult situation where a patient may use multiple drugs and be at really high risk for overdose. But we know from these data that if they stop using those drugs, they may actually, the opioids, if they stop being prescribed the opioids, they may actually have a higher risk of death, which is a real conundrum as a provider. That doesn't mean you should necessarily continue prescribing them opioids, but it means you have to try to address the risk if you're considering a taper or discontinuing opioids. And you need to think about tapering really slowly, because I'm doing it in a patient-centered way instead of these unilateral tapers because of the risks to the individual when you stop opioid therapy. Drug checking is another option, and this is fentanyl test strips are commonly provided, and they are, the best we have right now. We do need better technology. There's false positives with methamphetamine, MDMA, and diphenhydramine or Benadryl, and that is a problem because there's a lot of Benadryl and a lot of drugs, and oftentimes people who use methamphetamine want to find out if there's fentanyl in it, and it's tough to test. You have to dilute it in quite a bit of water, and that is a challenge for people. There's some programs that we're starting one in San Francisco. There's one in Chicago and a few others in the US, and then some in Canada and through Europe, where people can bring in drugs to be tested through mass spec or similar technologies to find out what drugs are in the community. This is less an individual level intervention, more of a community level intervention. We know that knowing that fentanyl is in your drug affects what you intend to do, but we don't actually know if it affects your actual behavior. So it's more research is needed in this domain, but we're at the point of basically trying everything. The next thing is to think about, this is the long-term thoughts, is thinking about poverty, income inequality, unemployment, social isolation, structural racism, these factors that have a huge impact on drug overdose death, and that, they're not affected by any of the interventions that I talked about. And it's hard to overcome the crisis that we're in if we don't have a long-term plan. So addressing these issues has to be part of the long-term plan. A couple more things. One question that we have is, why is the majority of fentanyl deaths attributed to both stimulants and fentanyl? This is a huge question. I love this question. I think these are probably really fentanyl deaths, frankly, and the methamphetamine or cocaine is just on board. There are not data that meth or coke actually pharmacologically contributes to the risk of opioid toxicity. They are mostly sort of markers of risky substance use behavior. So I think, but we do want more data based on data with heroin and stimulants. Those deaths are really almost certainly mostly heroin deaths. And I think the same is going to go for fentanyl and stimulants, but we need more data on that to confirm it. The next question is, how often is the fentanyl exposure unintentional? And in particular, I'm talking about when it's a stimulant and fentanyl. So there's a couple different perspectives on this. Most people, there's a well-known history of using both stimulants and opioids at the same time. It's really common. And we know that that stimulant opioid deaths in the past, they really looked like opioid deaths. They had similar demographics and comorbidities. So they were probably people who were intending to use opioids. And we know that people who use fentanyl tend to use more stimulants, reportedly due to the potent sedating effects of fentanyl. So there's a good argument that most exposures are intentional. The question is, could these be unintentional? There are definitely case reports, multiple case reports of people intending to use methamphetamine or cocaine and overdosing or dying from fentanyl. And the and fentanyl does appear very similar to methamphetamine and cocaine. So it's a fair question what the proportions are. We did a small project in San Francisco, and these are preliminary data, but from looking at the charts of people who had died from stimulants and fentanyl overdose, we estimated that perhaps about a quarter of these deaths that we expected to have a history of opioid use did not have a history of opioid use in their records. So maybe, we still don't know if this is actually true, but maybe about a quarter of these stimulant fentanyl deaths are unintentional exposure to fentanyl. And that, if it's that big, then that's an urgent concern. So some brief takeaways before we do our academic detailing training. Fentanyl is way more potent than other opioids. It's here to stay. It's not going anywhere. It's cheaper. It's cheaper, and people's tolerance has gone up and up. Our interventions still work, but we are working from a baseline that is 4 or 5 times higher than it was before. Treating for opioid use disorder, it is harder because of the higher tolerance, but we can do it. And we have to be really bold and try everything that we can to respond to the crisis. Okay, we're going to do a brief, John Walker has agreed to join me in a brief academic detailing session on opioids. And so we'll talk on fentanyl specifically. So we'll talk a little bit about that. The things to watch for, if you've attended these before, you know this. We're going to do a little introduction and a brief needs assessment. We'll go through some of the messages and close the visit. And it's been a minute since I've done this, so please call me out if I forget to do any of these steps. I will drop off the slides, and you can, if you'd like, you could pin John and me, John or me, or both of us as your image. Hi, John. Thanks for meeting with me today.
Absolutely, Philip.
So we were going to talk about opioids, and I'm looking forward to hear what's going on in your practice. But before we do that, about how much time do we have?
Oh, I think we got about 7 to 10 minutes.
Okay. I'm going to set my timer so that I respect your time. And I'd love to hear what's going on in your practice.
Okay, so I have been prescribing a lot of naloxone to my patients, but I'm just kind of like feeling like, honestly, what's the point? Because my patients are still dying.
Yeah. Yeah, it really is a terrifying experience. And I think a lot of people feel like we're kind of swimming upstream. Is that how it feels?
Oh, yeah. Yeah, I've lost 4 patients in the past 4 months.
That is horrible and heartbreaking. I'm so sorry that you're going through that. Yeah. So you've been prescribing the naloxone. I assume you prescribed the nasal naloxone. Is that right?
That's right.
Yeah. And is there anything else that you're doing or trying to do?
Well, I mean, I'm also trying to move more patients, see if I can get more patients, medications for opioid use disorder, like bupe.
Yep. And is it fentanyl that people are using, or what do you think is causing the overdoses?
Oh, I think it's fentanyl. I think that has seemed to like come into our community and just sort of like has steamrolled over people.
Yeah. So I think the first thing I can say is our interventions still work. Prescribing naloxone, it still does help. It does reduce overdose death. The fundamental problem is that with fentanyl, everything is 4 or 5 times worse. So if you would have had 1 patient die a year, now you're going to have 4 or 5 patients die a year. And when you add naloxone to that, you reduce risks. you reduce risk by, the risk of death probably by something around 30% or so. And so, if you were going to have, let's say you're going to have 3 people die and you gave naloxone out and only 2 died, and now you were going to have, with fentanyl, you're going to have, 8 people die and you give naloxone out and 6 people die. It doesn't feel very satisfying, but every life matters. So there's still a real value to it. We're just working from a much worse starting point now. I don't know if that helps at all.
It does.
The other thing is, are you X-waiver? Do you provide buprenorphine yourself?
Yes.
Okay, great. If not, I was gonna run you through the 4 minutes it takes to get your X-waiver these days. It's a lot easier than the 24 hours it used to take. So have you started anyone on buprenorphine who was using fentanyl?
Yeah, I have. I've started a couple, and I, and a couple actually, they, we started at sort of the regular, dose of buprenorphine. They unfortunately went into precipitated withdrawal, and then they just never came back. So I don't know how to, what do I do about that?
Yeah, I mean, once you send someone into precipitated withdrawal, it's pretty hard to get them back. It's tough. So the way that we've been dealing with that has been using a different starting approach, basically letting people stay on their opioid, whether you're prescribing it or, it's a little trickier if they're using fentanyl because you're worried about them using fentanyl. But if people continue on their current opioid and you start buprenorphine at the same time at a really low dose, and you're basically trying to move slowly over 3, 4, 5 days, switch out those receptors from the other opioid to buprenorphine, and you make that transition over time, and then they stop the other opioid. Have you ever heard of this before?
No, I haven't.
Some people call it microdosing or overlap initiation. I'd be happy to send you a couple of papers on it if you'd like.
Oh yeah, that would be great.
Great. There's a dozen different protocols out there. My favorite one is a 4-day protocol. If you do it too long, if you do 10 days, people lose interest. It's hard to do that for 10 days. If you do it too short, you have that withdrawal issue. But if you do about 4 days, seems to be a pretty magic number. And it can take a little bit of work to arrange things because you want to make sure people are taking the small enough doses, sort of the 0.5 milligram doses, which means they have to cut the films and stuff like that. So it's a little bit of work to set it up, but it's really effective. And it sounds like you are really committed to taking care of these patients.
Oh yeah, for sure. So I think I would love for you to send me all of that info.
Excellent. Is there a particular patient you're thinking this might be good for?
I actually do have one in mind.
Okay.
And they're going to be coming in, I think, in about 2 weeks.
Okay, great. So if I send you these papers, can I follow up with you, maybe next week, and we can talk about it and maybe come up with a plan for that patient?
Oh, that would be great. Yeah, absolutely.
Great. Well, I do want to respect your time, and I love talking with a provider who's really committed to taking good care of his patients. So thank you for all your work, and I look forward to talking to you again next week.
Absolutely. Thank you so much. This has been really helpful.
Great. So John, how did that feel for you?
Felt good.
It's easy when you get to play a compassionate provider.
Yeah.
Yeah, that for me, that also felt really good. You were kind. It didn't put me into any tough corners, and I was able to praise you for all of your work and give you a new direction that might improve some of your practice possibilities.
Yeah, and I thought it was especially, I liked the sort of trying to reinstill the hope, don't give up. It's harder now because of all the fentanyl that's present, but keep doing what you're doing.
Yeah, exactly. And then just so everyone can get a sense as to the course of the academic detailing, the introduction, I introduced myself. We had already interacted before the call. I did a time check to see how much time we had, which is really important. I did a needs assessment, which I really like a vague general needs assessment that allows the provider to drive the course of things. Went through key messaging and benefits. I had 0 objections to handle. Thank you, John. And then I closed it. And, you know, I usually like to get somebody to agree to do something different with a patient in a closing, you know, to try something out on one patient. So we got John to agree to try something out on a patient, but I felt like we needed to talk a little bit more about the intervention because this new approach to starting buprenorphine is a bit complex and probably requires some additional clinical support. That is all that we have. There is, let's see, a couple of questions in the chat. Please, if you have additional questions, please feel free to add them to the chat. One was, are patients having a hard time filling the Narcan prescriptions at pharmacies? Costs associated with copay high, not covered by insurance, doesn't have insurance. Great question. Not an issue for us locally in San Francisco, particularly for the publicly insured population. I do not know nationally if this is an issue. If anyone has any insights and wants to add that to the chat, I'd love to hear it. You know, the private insurance can have more issues with copays, and I think sometimes patients who, let's say, they get a little bit of Percocet for a acute pain problem, and they're told they have to get naloxone too. They can get quite annoyed at the additional costs that they have to spend, so that they have to pay. So there is some issues sometimes in that domain, and there may be issues with public insurance in some states. I do not know. And Renee Isaac mentions treatment centers need education. Yeah, this is absolutely true. I think substance use disorder treatment programs are frankly, I think, doing better than they used to in terms of addressing overdose. 20 years ago, the only way that they addressed overdose was generally telling people not to relapse because they'd overdose and die, and that was overdose prevention in treatment programs. I think they are much better today. They've come a long way, and there's always further to go. So definitely some education and training and making resources available for treatment programs to be able to incorporate some of the advances we've made in addiction medicine and some of the critical advances we need to make in public health to be able to respond to this crisis. And I agree, Renee, fentanyl is a game changer. It starts us from a whole different place that we're working from, unfortunately. Any other questions? All right, well, we will let everyone end. We'll end this a little bit early. Really appreciate everyone joining us here today. We at CIAO love working with you all and our partners, and the support that we get from the Centers for Disease Control and Prevention and the California Department of Public Health, and our home at the San Francisco Department of Public Health. So thank you, everyone. Have a wonderful afternoon.